Hello, I'm Scott Hamilton and welcome to the third half, conversations about people, planet and progress, usually somewhere between work, gigs, sport and the rest of life. Today's guest is Bhavin Visavadia, a senior oral and maxillofacial surgeon working at the sharp end of head and neck cancer care, and more recently a level 7 qualified coach and mentor. Now, we got all sorts on here: tech, leadership, business, sports, music, but reconstructing faces and restoring lives, well, that's a very different level. And what's really stood out to me when we spoke recently wasn't just the surgery, it was the second chapter, moving into coaching and helping people navigate pressure in a very different way. So, Bhavin, welcome. It's great to have you on here. I'm delighted that you've joined us.
Thank you very much, Scott. It's a great pleasure.
So what I tend to do at the start of these is just pass the mic across to people and give you a couple of minutes to introduce yourself and your journey, and then we'll dive into a bit more about life at the sharp end.
Yeah, brilliant. Thank you, Scott. So, as you said in your introduction, I'm a consultant oral and maxillofacial surgeon. I work in Northwest London. It was a unit that started 20 years ago when I was appointed as a virtual unit. A plan was there to bring together a cohort of smaller units into a hub, and that was groundbreaking. So we got together 4 or 5 consultants and then slowly started to build the referrals in. And naturally, the base referral for us is facial trauma. There's a lot of that about on a Friday night, weekend, and having a group of like-minded consultants working together meant that we could regionalize our service and also pool our resources. I'm a head and neck cancer surgeon, as you said, and part of my remit was to bring referrals and patients together in a most expedient way so that they've got rapid access to mouth cancer specialists and get themselves checked out to then go on with treatment as necessary. Over the years, we've grown those values of having those like-minded surgeons together, having a team that's coherent, has filtered down so that we now have a very strong training program. So we have trainees who often place us first within the rotation requests because they see that the quality of work that we put through, the coherence of the team, and just the support that they get over the years. And that's been really groundbreaking because we've helped develop a whole cohort of consultants who then have gone on and taken those skills further as well. So we're now our regional centre, probably one of the biggest in the southeast anyway, in a corner of northwest London, affiliated with a regional trauma centre. We also have colleagues who deal with facial deformity and helping children go from that, children and their parents go from that journey all the way through lives to then restorative surgery and to rebuilding lives. And of course, my own special interest, which is taking cancer patients, treating them and rebuilding their faces, and of course then integrating them back into society over the years of follow-up, along with my team and with the network that's out there.
Well, thank you for that introduction. And so I'd like to start there, and I'd like to just think about you a little bit. And I think you said to me before that you started out as a dentist, is that right?
Yeah.
Yeah. And moving into this field, I mean, what does it actually feel like for you operating at the sharp end of this kind of work, where the stakes are so personal for people?
I mean, it really is putting every kernel of knowledge that I have, that experiential learning I've had over the years. So I started out in dentistry at the age of 18 with a training which was really quite rigorous in 4.5 years. And then, of course, in that time, you're actually able to perform surgery, take teeth out, and operate on patients. And then I had a year in general practice, and I actually felt my academic really qualities needed to shine a little bit more. So I went back into the hospital sphere, and I was working with trainees and with consultants who would just push you along. You were the old way was a firm structure. So you were with in a team where you had the consultant who led, and you were very well supported in that team. So with that comes learning and exams. And so the Royal College of Surgeons was really my first port of call for my first professional examination, like a postgraduate type examination. And it was the highest level of examination at the time in dentistry, which is the fellowship in dental surgery. And then from there, you are working and improving your experience and your competencies. So from working inside the mouth, then working on faces. So clearly, then it's about fixing people up in A&E who've had facial lacerations, taking them to theatre, and all of a sudden you're developing these skills which you weren't really trained for.
Yeah.
You're then a surgeon in theatre repairing someone's laceration and doing it very neatly, and then managing their care afterwards and seeing them through their recovery afterwards as well. But of course, you've then got the bosses who are doing this complex work. So then you get used to this environment of, well, there's more.
Mm.
There's cancer surgery. There's weird and wonderful reconstructions. Really inspiring leaders. Really, I mean, those were the role models, and we stand on the shoulders of giants. You heard that saying from many years ago. So it's about how we that inspires you along the way. So then, when you're there with that patient operating, it's the most natural thing to do because I've been prepared for it. I have a team that's prepped. The patient has been taken through from the very early stages of the worry all the way through to, yeah, we need to do an operation, and lots of discussions along the way, lots of planning, and lots of systems in place that are quite robust now. That makes us more efficient. It means that we can bounce ideas off each other. The technology is there for us to do planning and discussions, outside of an operating theatre. And so also our operating times have come down for such complex work and complex surgery. So what does it feel like? It's one of the best places that a surgeon wants to be is in theatre,
Mm.
because you've got um, things under control. You've got the system the way you want it, and you've got the support. And that's how I would envisage the ideal theatre scenario. And when you have a team alongside that you've worked with for 20 years, then that really is just a nice day at work usually.
Was there a wow moment for you? And I kind of always think about this. The way you've explained this, and I was listening to the pace of your dialogue there when you were talking, that you slowed down at one point where you were like, and I was leaning over somebody in surgery. You actually, I don't know if you did it consciously or not, but and I was thinking, was that a wow moment when you suddenly realized for the first time that actually you were no longer just pulling teeth? Forgive me,
Yeah,
for
yeah,
oversimplifying it. I am now reconstructing somebody's face and helping them
yeah.
kind of restore their life.
There are moments that dawn on you, which is it's a realization that actually what are you doing? Who are you? And
Mm,
why are you there? And it's just it's fascinating because you imbibe so much from just watching and learning from the masters, from your bosses.
mm,
The the wow moments are there, and it's you then realize actually, yeah, I'm actually doing this quite well. But you also have the pat on the back, the encouragement,
yeah,
or in some cases, not the encouragement. You only get you get to find out when things go wrong.
yeah. Well, quite. Yeah.
So it's then, oh yeah, okay. So and surgery, things do go wrong.
Mm,
I know we laugh a bit, but things do go wrong. Head and neck cancer has a very high complication rate.
mm,
But how do we learn from that? How do we move forward? How do we support each other? How do our patients deal with complications? Because they know that things go wrong, because we tell them. We
yeah.
have to tell them. That's what consent is about. So, yeah.
And I think the stakes are high. I mean, I always think, somebody flipping a burger in a McDonald's or whatever, they burn it, the burger goes in the bin. Somebody getting something wrong in a technology world, a system goes down, it may affect money. Something going wrong in theatre or in medicine. I've always kind of, in my working existence, thinking the stakes are so high, and the pressure that comes with that must be kind of like a different level. And I did want to ask you about this, about
Yeah.
as you have evolved, and your thirst and appetite for learning, and looking up to these giants and chasing them. Have you felt the pressure increasing with that, or again is that pressure just slowly crept up, and something that as you've learned more and practiced more, and that you just, again, the pressure evolves with you as you evolve.
Yeah. I think pressure is dependent on the individual, the surroundings, and the environment that they work in. The levels of burnout are huge in surgery. So we have to be really aware that however I may have navigated my career and through complex head and neck surgery, not everyone would have the same experience.
Mm,
So as we get older and more senior, then the duty should fall on someone like me to highlight what that pathway is, what worked for me.
mm,
I'm a very reflective surgeon. What did I do well? What could we have done better?
mm,
And actually start to bring those conversations up early on, so that I'm not held up as this in this hierarchy. I'm actually flattening that hierarchy so that we can open up these conversations.
mm,
Otherwise, the new generations coming through do not get that same level of support, do not have that resilience built into them, or risk not having that resilience built into them, just because that structure that was the old way has potentially changed now because we work in teams, which are big. So there are lots more residents and trainees, and maybe not enough hours, contracted. In my day, we didn't have this European Working Time Directive,
mm,
and it's brought in for good measure. But we do need to have systems now that and make sure that they don't fail, make sure that they're there to support people at a very early stage. So yeah, high performance is all about building in those levels of communication, breaking down those barriers, but also them knowing that there is a very serious problem that we need to treat and sort, and that we're going to do it together with leadership at the forefront.
yeah. Great, thank you for that. And I think we'll come on and talk a bit more about this when we talk about the coaching that you do and the
Yeah.
work that you're now taking on more of. But I wanted to ask you about what you're really restoring, and we've talked about this a couple of times now about there's one part of this: you are performing surgery, yeah, but you're
So,
also restoring people. I think this is such an
yeah,
involved thing,
yeah,
and there's a real kind of psychological aspect to this. So when someone comes to you, what when I say they come to you, what have they really lost, and what does getting back to normal actually mean in those
yeah.
circumstances?
So let's start off with a patient through their journey. So if there's a typical patient who would come to me with something someone with a common cancer of the tongue, and they may have an ulcer, which might have been a bit sore, a bit niggly, and they may put it off.
Mm,
Oh yeah, we'll just put up with it, put some Bonjel or something that's going to calm it down. They might see their GP, they might see their dentist, but something that's persistent, that's a worry. They should be coming in after 3 weeks to see a specialist. That's what the pathways are designed for. So if you've got something that's persistent, come and see someone. So if they're coming to see me with an ulcer, then um, I would need to work within a time frame to try and get them diagnosed and managed and treated. What are they putting up with when they have the condition? They're not able to eat properly. They're in pain, something that's bleeding. Their speech is affected. Their confidence is affected. And because they're in pain, their emotional state may be affected. They may be a bit affected at work. And there's all the other things that go with that in their work environment and their personal lives. So when they come to see me, I may have a job to do in terms of taking a cancer out. That means taking away a significant part of a tongue. So if there's an ulcer which is a centimeter in size, a surgeon would need to take a centimeter margin all the way around it for for clear margins, because you don't want to leave any microscopic disease behind. That means then you have a defect in the tongue of say 3 centimeters by 3 centimeters, or maybe larger, and then how is that going to affect the patient in terms of their recovery, in terms of their speech or their swallowing? Alongside that, they have a neck operation to address any lymph gland metastasis, and then usually a reconstruction. If it's a bit bigger than a centimeter, they usually offer them a reconstruction. And that reconstruction would be tissue from another part of their body, typically the forearm, where the skin is quite thin and pliable. And you take the skin with its own blood supply. So it's a transplanted flap, we call it, a free flap. It's free from the body. It's their own tissue. And then that skin stitched into the side of their tongue, and the blood vessels are draped down into the neck and stitched with micro sutures. So then you have a living reconstruction. So that's one operation, one surgical procedure, but how many operations? A forearm operation, a neck operation, a mouth operation, and then the skin graft to go onto the forearm as well. So all of that to try and close the mouth cavity, because you can't leave that open.
Mm.
If you leave it open, they're not going to be able to speak, swallow, function, eat. So we're then looking at restoring an aspect of the tongue, allows the rest of the tongue, the muscle that's left behind, to work and move. And if the tip of the tongue is spared, I kid you not, you wouldn't be able to tell if someone is talking to you having had that sort of reconstruction.
Right.
So that is crucial. It sounds awful and it sounds fascinating, but it's just so that we can seal off the mouth, okay, anatomically, so that you've got saliva can stay there, food can stay there, and the tongue, that's the remnants that are there, can move. And then that is entrained with our speech and language therapists, with even with physio, to just try and help them to improve the quality of all of their tissues so that they can speak. And they can speak, but it's just that once all the swelling settles down, it just, a few things need to be relearned. And then the other thing is, of course, the mouth opening reduces a little bit, so to try and get their mouth exercising going so they can get their mouth opening again. And then it's the soft tissues that need managing afterwards as well. That's without any radiotherapy. That's just surgery. If surgery is curative and we look at everything afterwards, and if they don't need radiotherapy, then we monitor that patient for 5 years. Now, that's where the skills of coaching, mentoring, good doctoring come in, because you're monitoring someone very closely over a long period of time. And you see them every 6 weeks, you get to know them, you get to know their partners, they have ups and downs along the way. But we know that. We know that in our coaching world, there's ups and downs, but there's a goal, right, at the end. And that goal will be cure with excellent rehabilitation and return to life and back to as normal a life as possible.
Mm.
The psychological damage is untold. We don't know what that would be for each individual. Some people take it on the chin. Let's go, get back to work, move on. There are others who are just completely defeated by it. And so you have to tailor everything to each individual patient. And that's why it takes a team of dedicated professionals. And this is why I find the NHS is so fascinating, that we have got the ability to set up services like that can take patients from a really worrying time, which could destroy them, to then get them back to almost normality. It's a difficult journey.
It's an incredible journey, and I think if you go back to the start of that journey, it starts off with an ulcer in the mouth. I mean,
Yeah.
that's as you were talking there, I was thinking, where's this going? And what is the starting point? And in so many is, and you talk about pathways there, and how quickly do people realize that recurring ulcer of, I think you said 3 weeks there. If you've had a recurring ulcer for 3 weeks, go get it checked out.
Persistent ulcer, yeah,
Yeah,
definitely.
persistent ulcer. I mean wow, and that's why I love having these conversations, because if one person or 10 people or 100 people listen to this and then take that away and think, actually, persistent ulcers, get it checked out, because,
Yeah.
and I'm assuming that, as with most things, medical, the sooner you get it checked out and treated, then the better. The more
Yeah.
likely it is that you're going to have a positive outcome here.
Yeah. Well, while we're on that, Scott, can I just add, there are other signs and symptoms as well. The other one is, of course, a lump in the neck. And how many people have a lump in the neck and they say, oh, it's nothing. Oh, we'll just watch it.
Yeah,
Or we'll go to the GP a bit later on. But, that could be the first sign of something developing,
yeah.
because the lymph nodes in the neck drain the tongue, the back of the mouth, the tonsil, the throat, So this is really important that we remain vigilant, that we have these pathways where majority of the time we're actually reassuring people.
Yeah.
Those ulcers are recurrent ulcers. They're just common ulcers that may respond to topical steroid, for example, or when it's more persistent, when it is a tongue cancer, or if it is a mass in the jaw or something, that we are then resourced to get those tests done quickly and get them to treatment as soon as possible.
Yeah, and the key thing here is that, and we'll come on and talk about the system as it were.
Yeah.
But there is help there, and I don't think I always
Yes.
say this: don't be fearful of getting things checked out. Go and talk to people and get something checked out because it'll be good. Just on this, just to finish off on this psychological aspect as well. I mean,
Sure.
and I mean, you must have seen all extremes of how people adapt and
Yeah.
recover on that front from people who, as you say, just I'm not going to say shrug it off because that's kind of overplaying it. Life goes on. It's just one of these things. And then
Yeah.
some people who actually it probably just hits them, the trauma hits them even harder or terribly hard. Are you ever surprised by that, or is that just now kind of an accepted part of the journey? I don't know how people are going to react. We have to respond to whatever comes our way.
The interesting thing is you have to put trust in your team. So I have a clinic where from the minute the patient walks into the door, the receptionist will see something or will understand something, and will know that something's not quite right, or they'll relate to one of the nursing staff who may then already have picked it up and will come and tell me. So people are well trained to look at the non-verbal signs of abject just fear, and just worry. So the body language tells you so much about that patient, before they even have to open their mouth. You can see what that they really are extremely worried. And that's part of the training that you have as a doctor. You see, we talked about dental training, but then to go back to medical school and do I was fortunate, I got a year off medical school, but to go back and do a 4-year degree and to then go in as a mature clinician, to go back to basic sciences and then go onto the wards. And you have to be a little bit humble. You're a bit older than some of the people training you, or the same age as people training you, which is actually quite fun. And picking up those subtle signs. So when you're doing a psychiatry ward round, you've got, you're not the surgeon anymore, you're the psychiatry, and
Yeah.
when you're doing a neurology, you're a neurology medical student rather than, so you're picking up different skills along the way. And that I thought was just amazing, an amazing way to learn medicine as a mature graduate. And that I took on a lot more.
And again, I think you make a kind of lovely point there, if I may say that. And again, I think people forget this when we turn up that people get frustrated with receptionists, with secretaries, with people in the system, and again, you've touched something there with me that I hadn't quite appreciated as much. That that kind of front of house, if you will, that when people walk in the door.
Yeah.
To your words there, people are trained to look for signals, to look for nervousness or whatever, and then, I don't know how you do it, but it clearly happens that kind of gets fed back in. So it's not just the person at the back end who's doing the surgery, and you've mentioned the word team. I don't know how many times now that this is a real
Yeah.
team effort from the front door right back to the kind of aftercare and everything else that to put people back together and be back on the road of life.
Yeah. Absolutely, and I think teams are the only way for it's. You find that people who work in the NHS, particularly, are there because they've got a sense of purpose. It's our NHS; we will all be users of it.
Yeah.
So you've got to take some pride in that. And so if you're a member of a team where you're integrated, where your consultants can come and talk to receptionists, you're not just working in silos. Everyone's working together. There is a shared purpose.
Yeah.
And if you make it clear that what they're doing is helping that patient's journey, and I don't have to do that very often. The patients themselves will say, it's a great team. Thank you to you and your team,
Yeah, yeah. Well,
which is
well, it's great, and I mean, it must be so rewarding for not only you but the team to hear as well. And again, I don't know whether it's a terribly British thing. We're very good at kind of complaining when things go wrong, you know. Listen, I don't want to get into a kind of downward spiral about the press and you know, God forbid, social media, but we're very good at shouting out when things go wrong. We're not as good as what we could be at patting on the back and saying, you know, well done, thank you,
Yeah.
both
Yeah.
horizontally and just when we get good service.
Yeah, and there are other things you can get out of. I think rather than reward and recognition, I think it's important if you're going to be leading a team that you recognise the people in your team. That's goes without saying. There are deficiencies wherever you go. No life is no. It's not perfect, is it? So you've got to do what you can, and I think be honest. There's things you can achieve, there's things you can't achieve,
Yeah,
and sure, if we can reward people, fine, we
yeah.
should do.
Yeah, that's a reality check, isn't it? You know, all across society. So listen, and I think we're naturally evolving here, and I think that's good into you know, if we zoom out a bit
Yeah.
and talk about the healthcare system per se. You know, what have you seen change in the healthcare system over the years in terms of that perhaps pressure on individuals and on teams as well? How have you seen that evolve?
The pressure is always there. At the moment, I think you'll appreciate that we are under significant pressure through waiting lists. You'd hear in the media there's waiting lists for issues. There's delays to diagnoses. There's overburdening of the workforce. There's lots of doctors who are leaving the NHS early, perhaps. Those who are trainees or residents who are deciding to go to other countries where the grass may be greener. We have to work with that. We have to work within that. And post the pandemic, we've had some real challenges. During the pandemic, we were the most challenged. We lost colleagues. We had to reorganize just how do we run services. Waiting lists just got bigger, and people's access to physicians, dentists came to a halt almost at one stage. So it's how do you pick up from that to then have a free service for all? So we work with um, our current government. We work within our resources. We do the best we can. I think technology has been a real savior. The
Mm,
fact that me and you can have this conversation has meant that we can have secure conversations discussing patient treatments online. We can have management meetings without people having to rush in and out of hospitals and that travel time and parking cars and getting on tubes and things. And that's meant that you've introduced some flexibility. So there are some good things that have come out. And also technology has evolved even further. You're hearing about real investment in robotic surgery, which is just so important when you've got cavity surgery like an abdomen, where so much can go wrong with an open laparotomy, a big incision, and that robotics can actually help give you much more accuracy and minimal access surgery, and can get patients out of hospital that much quicker as well. So there are some real good things coming through. And with technology, we have to embrace it. And also with AI, you can see changes coming through as well in terms of how notes could be recorded and records can be looked at across trusts and units. So we've had pressures along the way, and this is always going to be part of it. It's just how we deal with it. And I think the safety has got to come from cohesive working.
mm.
If you're working as an individual without that support, how can you sustain that? How can you be a high performer?
So I'm glad you touched on the technology aspect there, and I think you said probably three things that resonate with me. And if I take a step back, again, if you read the press, we'd believe that AI is the devil incarnate and the world's going to end. And again, part of what I've been doing on the third half on the podcast is to say we've got to look at the pros and cons, and we have to manage through this period of change, but don't lose sight of the
Yeah.
benefit that technology can bring. And as you say, with note taking, you know, with sharing of information and everything, the opportunities are great. I also think one of the things that resonates with me is triage. if you can talk to a GP on the phone and get through that very first call, when, as we know, we pop down to the GP, it can take a while to get an appointment. You're in and out, and I don't know what the average time is, but you're probably in and out in less than 10 minutes. And the likelihood is you'll get sent home with, nothing, or you'll get a prescription, or you'll get referred. And if we can do these things online, then that's goodness as well. It just takes pressure out that front door of the system. And then the third thing is robotics and the opportunity that that gives as well. And to hear that from you as a senior and respected surgeon, I think is a really really important thing to realise, that there's goodness in this. We can't just jump straight in and do it. Everything, like all things technology related, we have to evolve with it, and it has to be tried and tested. But if it's helping you in terms of what you do and relieving some of the pressure, then surely that's goodness.
Exactly. I think, but also with technology, you need time to train. So you've got, as well as the pressure, you do have to train our future surgeons. So those who are coming through do need to pick up. It's a craft specialty, what we do with our hands, how
Mm,
we learn the fine motor control, the hand-eye coordination, the spatial relationships, working in those environments, along with the environmental pressures.
mm,
So you may be, it's so important to be able to train someone to be able to operate and to embrace that technology and to run with it, so they can build up their skill level to a high level, so that we put, of course, why we're doing all this is to keep the patients as safe as possible, give them the best care possible with the highest degree of technical expertise.
yeah. And how much of that realistically, and in what timescale will we be able to do truly remotely? Because, and again, I've worked in tech all my life, and I do remember sitting in labs somewhere 10, 15 years talking about, hey, a surgeon, a consultant in China will be able to operate in.
Yeah.
I think China and the USA is probably the worst example I could use of this, but
Yeah.
like across thousands of miles, is
Yeah,
that a realistic
yeah,
proposition?
it's happening. It's happening already, and there was something in the press recently about a consultant who operated remotely from one country to another. But that's fine. It's a great to show how versatile this can be and how it can be used. In day-to-day practice, I think it's more about how can we benefit, how can others benefit from our experience here in the UK,
Hmm,
and that's talking about global health and helping um, doctors in far off places who may not have all the resources but need the surgical input and the surgical care from the UK.
interesting. Okay. I want to talk about the move into coaching for you. We are
Yeah,
now fellow coaches. I think I can say, having passed my dissertation
congratulations.
this week. Thank you very much.
Many
I'm, a,
congratulations.
I'm only 2 years behind you. And we were just talking off air. We know how difficult it was. So,
Yeah,
so listen, you don't just drift into a coaching, career alongside a
yeah.
surgical career. So what prompted that move for you? Let's start there.
So it's really at a time in my career when I realized that what I had been doing all this time, the conversations I was having, the support I was giving patients, the level of everything we've talked about, bringing the conversation level to one that the patients can understand. They can you're trained to a level of communication which is actually just so amazing, because you have to, you're placed in these situations, you don't know what's coming through the door usually, and you have to take a patient from being in a situation where they're frightened for their lives, to then putting their trust in you, having the rapport, and then having the shared goal that you're going to be able to offer them curative treatment, and then supporting them on that journey of follow-up and the worries. So those conversations were taking place anyway. It was only when I went on a coaching course, and someone said to me, "Well, how long have you been coaching for?" And I said, "I think I've been doing this all my all my surgical life." And because they said, "Because you're quite good." I said, "Well, thank you very much, but I think I do this all the time." and they suggested I do a level 7. I said, right, I'm just a bit of a, yeah, sure, okay, I'll do that. And I didn't realize how much work was involved. So there's textbooks there that I've read, and there's work there that I've done. And I came up with my own dissertation, which was about incorporating coaching and mentoring into NHS healthcare, and looking at how can we take small conversations and have that ripple effect that is going to filter down the organization. And it was just that realization that that's what we needed to do. And I'd been I'm a leader grounded in clinical experience. I've been a clinical director before. I ran a whole service. That's a huge thing to do, as well as a jobbing consultant, to be able to run a department at a very high level and work meeting with executives. And when you then see the levels of burnout and in your surgical workforce, or disquiet or problems, that's when I just putting everything together. It needed a period of reflection. I took a couple of months of I call it a mini sabbatical, just to unwind, relax, and decide on what I wanted to do. Those I should have taken, perhaps should have taken longer, but actually it was when I managed to complete my level 7 dissertation when I thought, actually this is now something that I can push forwards. And so far it's been it's a really interesting journey. If you say, even just a couple of years ago, it's my own experience, that if you say, yeah, I'm a coach, and you get this sort of look. I don't know if you. Hmm. I went to the States and I met lots of coaches. I went to a huge coaching sort of expo, and it was just amazing. Just high energy and lots of enthusiasm, and lots of people who were supporting in all different avenues of life, and making a career out of it. And I thought, this is interesting. Um, Mine was actually it's more of a it's more of a give back. It's more of a service element in this phase of my career. If I use the word mentoring, that hits home. That hits home in a big way, because we all love mentors. I've got my own mentors. I've got my own role models. I've been told I'm a mentor, and I thought, okay, well, let's try and see where we go with this. So the mentoring aspect is actually what surgeons, I think, are really happy with initially, and with that will come coaching as well. And the difference being that, of course, the mentoring aspect, you know, it's a catalyst for whoever the mentee is. They drive the discussion. They come they come to me for whatever aspect of their advice that they want. It may be career advice, it may be interview practice, but it's about what they want to drive. And so with that, and I'm very fortunate at the Royal College of Surgeons of England that I'm the council lead for mentorship. And so we've there's a lot of work that's gone on there to try and build a platform that links surgeons together. And we ran a pilot last year very successfully, and this year we've opened it up to members and fellows of the college. And that means that I've had they've got access to people like myself, and lots of my colleagues who mentor have been doing this anyway. And then I put it to the test just recently, and 4 or 5 different candidates came through, and it's been just fascinating journey. Just having short conversations and building that relationship and moving it forward. So the feedback has been excellent. So I'm very excited about that.
And listen, well done you, because I very different industries, but like you, I find that you've been, let's just say loosely, giving advice for your whole career, and people say, "Oh, you're a good coach." You think, "Oh, it's interesting," and then people come and say, "Can you help me? I'm at a junction. I've got, yeah, okay, I'll help you." And for me, there was a moment, and I think what you're saying was the same. Well, if I'm going to do this, I better do it properly. Yeah, I'm going to go and I'm going to do my training to be a
Yeah.
coach, so I can do it properly. Because, and forgive me, there's a lot of coaches out there who I think hit a certain point in life who think, yeah, do you know what? I'm kind of going to semi-retire now. I'll be a coach, And I think, well, this is really important for the coachees and the mentees that you get this right, and to invest your own time and effort in it it's huge. Kudos and respect to you for doing it, because it is so important, especially in your field, for what's coming next.
Yeah.
And I also think this point between coaching and coaching and being a mentor is significant as well. Coaching, I think, always is a little bit more pull, let's pull it out of people. And the mentoring is a bit more. I tend to find people come to me, well, what would you do or how would you do it? And that is a bit more of the mentoring, and getting that balance right is incredibly difficult as well, depending on the individual that you're sitting in front of.
Yeah.
How does that
I'm
manifest? Sorry, go on.
no, I'm just pleased that we have an opportunity to have these conversations. That's what I'm really chuffed about. Actually, by saying, "Oh yeah, sure, come and have a chat."
Mm.
Let's. Do you want some coaching? Do you want to, as a group, shall we do a group coaching session with my residents? And the times we have done it, it's been fully attended, and we've allowed an hour, but it's gone on, and they want to continue. The conversations want to continue. So it is actually, it's so important because it's really helping people.
Yeah, and I was going to ask you about that. I think you've just answered it. Is how does it manifest itself? The balance between individuals and groups, and where this come from. How localized is this, and how much is your kind of knowledge and experience now spreading out, across the country and other geographies in terms of what
Yeah.
you do?
Yeah, I mean it's slow, isn't it? It's only a startup at the moment. I think it will gain momentum. I hope it does. I hope that people are encouraged and enthused to be able to recognize the importance of this, not just for the trainee or the residents or whoever they're coaching, but for the coach and mentor themselves. This is something that can save careers. So if you think of a graph that's going that way up, okay, the first phase of a consultant's career is actually hard work, pushing, getting the cases done, building that experience up, and learning from that and embedding that and building their team. Okay, and then you reach a sort of a plateau in their sort of quality of life because well, there's all sorts of other factors, families, or there's the work becomes very familiar, or the environment is becoming a little bit burdensome, and they're not able to progress that much further. Go now to the sort of third phase, a consultant in their 50s, going off towards the last phase. And often you see the sort of decline in their quality of life. Might be ill health, might be that there's some medical issue, or their dexterity or their vision or something like that. That then means that actually there's the downslope of this curve, which could also be burnout.
Mm.
Okay. Now, if you bring in coaching and mentoring initiatives at an early stage, and just the fact that it exists, there's training available, the support network, the coaching supervisors, the coaching, peer groups, you may find that that curve carries on going in a plateau and then raised slightly, so that the quality of life of the individual really does improve. And
Mm.
that fits with lots of other theories on sort of the actual how you start off with life as trying to build up your skill set, and then you become the sort of master of that skill set, and then the final is the payback, the service aspect to it, where you're actually a very reflective person, a reflective surgeon who is then able to help others and motivate them and move them further forward as well. That I think is a model that is really quite a good model for what the sort of work that we do.
Yeah, absolutely. And listen, we talk a lot on this podcast on the third half about one of the points you've touched on there is about preparing for that, part
Yeah,
of your
yeah,
career, and when other things hit you. So, and people in industry preparing for this fractional life or portfolio life or semi-retirement,
yeah.
they think it's going to be easy, but the impact, both emotionally, economically, and everything else in terms of their life, and if they're in their 50s or even 60s, they could have another 20, 30, 40 years ahead of them. And that's a kind of
Absolutely.
like, wow, so that kind of helping. But you did say one thing there that I think is super, super important at the head of that little vignette. And I love it. You're not looking at this as a kind of new profession. That you use the term give back. And I think that is just so important that what you're doing in your coaching and mentoring and advisory stuff is giving back and trying to create, and help develop a next generation of people to come through and pick
Yeah,
up the baton, as it were, of what you've been doing. So that's a
yeah.
super, super point.
Thank you. Yeah.
Listen, I've got a few quick fire questions for you to bring us to a
Okay,
close here.
thank you.
This is the unrehearsed bit. So, number one, and you touched on something there, which is a good hook here. Do surgeons make terrible patients?
I think that's true. Definitely. We're supposed to know it all, so we do know it all, don't we? That's the issue, isn't it? And can we step back
Yeah,
and put? Yeah, yeah, we do. I think.
terrible patients. Okay, good, got it. Best or worst waiting room music you've ever heard?
Interesting. It's actually theatres that we have the music, believe it or not. So we have gone from anything from ABBA to Greek country music. So it was like folk music. Yeah, interesting. I think the best has got to be something classical. That is just calming at the end when you're doing your microsurgery. That's great, and then something celebratory at the end. I think patients sometimes get horrified that we actually play music in there. We actually say it's really important because it does give you that chance to have that level of sort of maybe a bit of normality in there. And so something like ABBA or something would be playing in the back. I have no choice in the music, by the way. But I will say, can you put something classical on? And that's great. But we finish on a high, which is always nice. And then it's whatever they want. Yeah.
I just love that. I've got an image now of you walking into surgery, all kind of gowned up and cleaned up, and thinking, "Oh no, it's the Greek country music." Is there a big red button?
We have asked for the music to be changed on some occasions, or sometimes it's just quiet. Some of my colleagues just want complete quiet, but it's I think it's great, and it does tell you a little bit about their personalities as well, which is quite nice.
Yeah,
Yeah,
you should. I'll send you a clip to Peter Sandberg, who I interviewed the other week, who's
yeah,
a pianist, and his music is beautifully calming. He was diagnosed with ADHD, and he started writing music to calm himself, and now it's grown, into its kind of own genre. And finally, what actually helps you switch off? What do you do outside of
so
work?
I'm very, very active in making sure that I protect my own personal health, mental health, and switching off is really important. So going to the gym is actually quite important. That I find really prepares me for the day ahead or the week ahead, and so I go quite frequently. Eating well is good. I love to go out, and then music. Actually, I didn't realize how important it was. But the minute the pandemic ended, it was about let's go to as many clubs and jazz clubs and soul and R&B, whatever. So anything that came through, it was so it's been really, really important to me. So
Fantastic.
yeah,
Bhavin, that was brilliant. I genuinely, genuinely really appreciate you coming on. There's so much in there, not just about healthcare, but about people pressure, coaching, and what really matters. So thank you. Enjoy the rest of your day, and I hope to catch up with you soon.
thank you very much. Thank you, man. It's an honor. Thank you.
Cheers.